Welcome, medical coders, to Achieve More in 24. We're reviewing our monthly charts, and today we will be looking at PCP chart, primary care physician chart number 1. And so let us move to that chart for a moment. Let's go through it as it is. And let's blow it up a little bit. Let's get back to the top. Okay, so I'm going to bump it up a little bit more here. And we have patient MacDonald, male, March 15th, 1980, date of birth, age 43. Okay, and he visited Dr. Olivia Richards on November 13th, 23. Patient presents for routine follow-up to manage chronic medical conditions. The patient reports stable symptoms related to diabetes, hypertension, and hyperlipidemia. No significant changes or exacerbations noted since last visit. We got the review of systems, which, for E&M is not required, but it is good, good documentation practices, etc. Good subjective, record of subjective information for the patient. Medication review, metformin, lisinopril, and atorvastatin. No known drug allergy. No known drug allergies. The patient reports moderate exercise, balanced diet, non-smoker, occasional alcohol use. No significant changes in family medical history reported since last visit. We've got basic medical exam here, a physical exam, well-nourished, no acute distress, blood pressure. We got vital signs here. Everything looks fairly decent. Regular rate and rhythm for the cardiovascular, no murmurs or abnormal sounds. No focal deficits in neurological, and no joint abnormalities noted in musculoskeletal. And we have under the assessment, we have diabetes well-controlled, hypertension well-controlled, and hyperlipidemia stable. Okay, and so that those phrases, well-controlled, stable, that is documentation that the provider monitored the condition. Okay. As opposed to assessment, diabetes, assessment, hypertension, assessment, hyperlipidemia. Those, would be, there would be no assessment. It would only be a diagnosis, the listing of a diagnosis code. Okay, so we'll talk about that a little bit more in a moment. Plan, continue current medication regimen. Okay. Schedule follow-up in 3 months. Lab testing ordered, an A1C, a lipid panel, and CMP, comprehensive metabolic panel. Patient education on lifestyle modifications for diabetes. Patient educated on the importance of medication adherence, regular monitoring, and lifestyle modifications for optimal health. Patient instructed to schedule a follow-up visit if any changes in symptoms or concerns arise in the provider's signatures. So we're gonna see how we would fill in, how our coding would fill in a standard 1500 form. Okay, so let's take a look at that. And so, just a reminder, for all medical coders, okay? Code all documented conditions that coexist. All documented conditions that coexist. And I'm going to have another reminder on diagnosis coding here in a moment, okay? So we have E11.9 for the diabetes. We've got I10 for the hypertension and E78.5 for the hyperlipidemia. Okay. And so I do want to remind everybody, okay, and that there's a certain segment of the coding population, and particularly those who and I was guilty of this early in my career. Okay, so I'm not lecturing. I was as guilty of it at one point as others, but oftentimes there's this tendency to. So we have an E&M code there, right? We have an E&M code, and there's a tendency to assign a diagnosis just to just to have something tethered to that CPT code. Yeah, that's not how diagnosis coding works. Okay, you have 3, 6, 9, 12 options here, 12 spaces, 12 fields for diagnosis codes, and in box 21, okay, there should be every diagnosis code that is documented in the record. Okay. And so here we have an E&M code, and all three relate to the E&M code. Okay. Now, later in the program, and throughout, this is kind of a continuous program. So at some point, we're going to look at charts where maybe a particular diagnosis applies to, like, let's say a laceration, and let's say there's a laceration repair. Okay. Let's say there's an E&M code and a laceration repair. And so the laceration repair, if there's a laceration, injury diagnosis, that may be, under the diagnosis pointer in box 24E may point to that. And let's say the patient had, I don't know, a major head injury. Okay. And that may, relate to the E&M code. But if everything documented in the record should be in box 21, and the diagnosis pointer, there should be nothing in box 21 that is not accounted for in column E. Okay, it shouldn't happen, and everything documented in the encounter should be in box 21. Now, there's a question that might come up that says, well, what if there's more than 12 diagnoses? We'll cover that. There is a way to deal with that, and I'm not going to waste time today. Just getting started here in the program, we will cover that. Okay, but there is a way to do that. Okay, but just remember, you should code all documented conditions that coexist. Okay. And so back to the official guidelines for coding and reporting. And I started to say that, many coders, depending on how they arrive at their role of medical coding. Look, I coded for 10 years before I ever got a certification. Okay. Now, whether I was certified or not, does not make whether a coder is certified or not, no matter who they're certified through, none of that matters. If you are assigning codes, you are subject to all the regulatory compliance issues, whether you're certified or not, no matter what your certification is, no matter who it's through. Okay. And early on in my career, I was working in medical offices, and I was working for doctors who wanted to get paid. They want, so the focus was on procedure codes, the reimbursement codes. Okay. And it was never, unless the diagnosis was so off that that the claim got denied for the diagnosis coding was not anything that was looked at or emphasized. Okay. There are 3 code sets. Of course, there's ICD-10 PCS for inpatient, but for outpatient, there are 3 code sets: CPT, HCPCS, and ICD-10-CM. They are all required by law, and they are all, when they're required by law, and adherence to the guidelines is adherence to the guidelines for each of the code sets. Okay, so in case you've never seen the official guidelines for coding or reporting, or unless you never read the first page, let's do it. Adherence to these guidelines is required under the Health Insurance Portability and Accountability Act, or HIPAA. This is required by federal law, folks. Okay. Consistent, complete documentation in the medical record. Okay. So when I want to go back to code all conditions that coexist. Okay. And we'll be looking at this more throughout the program, and you're going to see these messages in the great majority of our presentations. A, because there is no such thing as reinforcing it too much, and also, somebody may be looking at a presentation and they haven't seen others, and so we're going to be repeating this in each presentation. Okay. So how did we get to a 99214 on that office visit code? Okay. So we had diabetes, hypertension, hyperlipidemia, all monitored. So they're sufficiently documented, not just listing a diagnosis code. Okay. And so we have 2 or more stable chronic illnesses, right? So we're at moderate for number and complexity of number of problems. Okay. Now we're moving to the next column, and we have ordering of each unique test. And remember, we had 3 tests ordered. Okay. And if you look down in the left-hand corner, under the amount and complexity of data reviewed and analyzed, each unique, you see the where it says ordering of unique test and the asterisk, each unique test, order, or document contributes to the combination of 2 or combination of 3 in category 1 below. Okay, so we are at moderate in the amount and or complexity of data to be reviewed and analyzed. Even if we were not, okay, we're going to move to the risk column. In this particular case, we could get to the 99214 no matter if something was less in column 2 or in column 3, we'd still make it. Okay, so let's look at the table of risk. Prescription drug management. Okay, and it said continue current medication regimen. All right, now this is a very, very common challenge for many coders, okay? Because the guidelines do not define prescription drug management. So I'm going to help you out with that right now, okay? Before I do, if you've ever struggled with the definition of prescription drug management, okay? And if that has come to this day, today, we're going to solve that for you, okay? But if you have gone however long, 6 months if you're a newly certified coder, a couple months, couple days, couple weeks, you got a couple of years, 5 years, 10 years, this has been a lingering question with you. What did you do? How were you getting by? What was your understanding of prescription drug management? Well, here is the thing. As I said, the guidelines, the procedure manual does not really define prescription drug management. Okay, so let us do that for you here. Okay, I have here, we're going to look at a couple different slides from a couple of different MACs, Medicare Administrative Contractors. Okay, this particular one is CGS. Okay, and so one caution is, now these are pretty consistent. Okay, So there shouldn't be any digression between the MACs here, okay? And we'll prove that by looking at several different MACs. But, you know, if there's another coding scenario where you have a question, if you're coding for Medicare, then make sure you go to your particular jurisdiction's MAC and, you know, go to their frequently asked questions, check their LCDs, local coverage determinations, or what have you. But so CGS, with reviewing medications, determining that the dose is correct, and continuing medication qualify as prescription drug management. The medical decision making to adjust any prescription medication when addressing and managing a problem or disease requires a higher complexity than refilling or continuing a medication. Therefore, the documentation must be clear and concise when describing why a prescription medication was changed or continued. Simply providing a list of the patient's medications or stating reviewed would not be considered prescription drug management complexity. The provider may also choose to use qualified factors. I'm sorry, that's a time thing. So now this one, I chose this one because this one is, I think that answer is clear as mud. Okay, it says the medical decision making to adjust any prescription medication when addressing and managing a problem or disease requires higher complexity than refilling or continuing a medication. Okay, so it really does not say yes or no. It kind of leaves a question. Okay, so if you are in the jurisdiction of CGS, you know, you should exercise caution. However, what we're going to look at is other MACs, okay, and you know, and look for the continuity here. So again, this is First Coast Service Options, which is a CMS MAC, okay, and during an evaluation and management visit, what constitutes prescription drug management? Prescription drug management is based on documented evidence that the provider has evaluated the patient's medications as part of a service. This may be a prescription drug being written or discontinued, or a decision to maintain a current medication or dosage. Okay, so you'll see simply listing current medications is not considered prescription drug management. Prescription drug management does differ from drug therapy requiring intensive monitoring for toxicity. And of course, that would be a higher level of risk. But so here, First Coast does answer the question, okay? A decision to maintain a current medication or dosage would constitute prescription drug management as far as First Coast is concerned, okay? And so let's move on to Novitas. When can prescription drug management be credited in the medical decision-making risk of complications chart? Credit is given for prescription drug management when documentation indicates medical management of the prescription drug by the physician who is rendering the service. Medical management includes a new drug prescribed, a change to an existing prescription, or simply refilling a current medication. The drug and dosage should be documented as well as the drug management. Okay, so again, I think we got one more here, or maybe even two more. This is NGS, National Government Services. Again, another CMS MAC. Please define prescription drug management relative to MDM. In order to count prescription drug management, there must be documentation of at least one of the following factors. A prescription drug practitioner is evaluating the appropriateness of using for the patient and or continuing to prescribe for the patient. This documentation on the prescription drugs that are being considered and a reason why they are being considered. Documentation of a decision to initiate a new prescription. Documentation of a practitioner's decision to discontinue a prescription drug or to adjust the current dosage relative to changes in the patient's condition. The patient condition, possible adverse effects, potential benefits of the patient using this prescription drug. So back to letter A. a prescription drug that the practitioner is evaluating the appropriateness use of the patient and or continuing to prescribe for the patient. So again, NGS says continue present medications qualifies. Okay. And Noridian, please explain further prescription drug management. Prescription drug management does not require a new drug, a new dosage, or discontinuation of a current prescription. The medical record will show the physician work to determine the medical necessity of the prescription drugs. An encounter documented as only a prescription refill without documentation of a problem addressed would not suffice. Now, here in our case, we had the problems addressed and we had the medications continued. Okay. Now, as you've seen in one or two of the other answers from other MACs, you can also count prescription drug medications considered but not given. Okay. And it describes why. It could be a patient choice. So I have hyperlipidemia and I refuse to take statins. So the doctor still gets credit when I go to the doctor and he says, you know, your lipids are high. You really should be on a statin. And I say, no, thanks. Okay. It's not his fault that I'm saying no. So something to consider. Okay. So if prescription drug management has been an obstacle for you, hopefully that clears it up. And for those in our program, we have support 365 days a year. So if you need further clarification on that or assistance, please reach out to us through any of the means of support. And we would be happy to go over that again with you. Okay. So finally, for this encounter, let's look at risk adjustment HCCs. Okay. And now, anybody who assigns codes impacts risk adjustment / HCCs. So I hear people say all the time, well, I'm a Pro-Fee coder. I'm not an HCC coder. If you're assigning codes, you're an HCC coder. Okay. Whether you have an understanding of the methodology or not does not mean you're not an HCC coder. You are an HCC coder if you are assigning codes. Okay. You have the responsibility. Okay. And so if you are not interested in knowing the how or the why or the, whatever, then please be sure that you are following the official guidelines fully and accurately. Then you should be okay in regards to HCCs. Now, I highly recommend at least a basic understanding course in HCCs. You don't have to go, if you're a coder in a doctor's office, having an understanding doesn't mean you have to go get a certification. Okay. But it would be highly advisable to understand how your work impacts this, because HCCs, HCCs apply to both Medicare and commercial patients, both Medicare patients under the Medicare program, commercial patients under the Affordable Care Act. So again, it's under the umbrella of federal regulations. So it's advisable to be knowledgeable in the methodology and your responsibilities under law. Okay. So anyway, with that out of the way, so we have I've pulled out the diagnoses. We have E11.9, type 2 diabetes without complications, and I have I've highlighted the particular columns that would apply here. Okay, the patient doesn't have ESRD, so we're not worried about that. We're not worried about V22, and I should have gone over to V08, so I apologize for that, but it doesn't matter because you'll see, although in the bottom one, the RxHCC number is different, but in either V05 or V08, each of these qualifies for an RxHCC. Okay, so the only the only condition that we have that is an HCC is E11.9. You'll see right now we are transitioning from a version 24 to version V28, V24 to V28. So in both, it risk adjusts. Okay. Hypertension does not risk adjust under an HCC, but it does under an RX HCC. And hyperlipidemia does not risk adjust under an HCC, but it does under an RX HCC. Okay, so without giving you a full course here, that's not today's agenda, but HCCs primarily relate to those those benefits under Part A and Part B of Medicare, and an RX HCC relates to benefits under Part D of Medicare, prescription drug coverage. Okay, so so in E11.9, it qualifies for an HCC under Part A and Part B benefits, as well as Part D benefits under for hypertension and hyperlipidemia. It is under prescription drug benefit only. Okay, there is more to that, and that's why I do suggest I really do suggest a understanding, a deeper understanding of risk adjustment, through a more in-depth course. It doesn't have to be a full certification preparation program. We have a boot camp that is sufficient if you're interested, but again, this is all federal regulation, so from a compliance standpoint, it is wise to be knowledgeable. So that is this primary care chart. Hope I haven't missed anything or left any questions out. If you do, if you're part of the program, we are here 365 days a year for support. So if you have a question about this chart, please feel free to ask, and we will see you in the next chart.